Well, I'm delighted now to be joined by Dr. Jennifer Dixon, co-author of the paper Reforming Healthcare in the USA and England. Jennifer, thank you for joining us.
Pleasure.
Now, the healthcare systems in the USA and in England are poles apart. What was it that prompted you to study them and look at the differences?
Well, as you say, there's a lot of heat and light about, America here is a pariah health system. We don't want to copy it. In the US, the NHS is a pariah health system which doesn't want to be copied in the US. But beneath the waterline of all that political rhetoric actually is quite a lot of interesting technical changes that are happening to progress healthcare in the US, which actually are very similar and of interest to us over here. So if we could learn from such a bigger system, in particular how these new developments are progressing that are more technical, then I think we should be learning as much as possible from America as we are from other countries. And because they are bigger, they have a lot of money, they've got quite a lot of technical development in some areas, and they do a lot of research and evaluation, we have a great deal to learn. So we shouldn't turn our face against America because it's grossly unfair, spends masses of healthcare dollars, and is fairly wasteful. We should learn and see beyond that to these more technical areas, which we've tried to detail in our paper.
Can you also just briefly remind us of how healthcare is funded and provided in the two different countries?
Yes, well, the US health system famously is about 50% funded through taxation and covers publicly the over 65 population under Medicare and poorer people under Medicaid. The rest of the financing is done through private health insurance largely. So as a result of that imbalance, where people who are poor are not necessarily covered by Medicaid, they may not be able to afford private health insurance. So America, with a large population, has had about 37 million people who are uninsured. So there's a kind of gross inequity built in. Our system is funded largely through taxation. So of all the 8.9% of GDP spent on healthcare, all bar 1% is spent through taxation. So we offer the whole population benefits. They are comprehensive benefits, and care is free at the point of use, whereas in the US there are significant insurance payments to pay, plus also co-payments, which puts people off receiving healthcare. So a very different philosophy and a very different way of financing healthcare.
I wonder if we could look at a few major areas and just sort of compare the differences and the contrast between them. Could you start by telling me a little bit about the contrast in terms of the financial measures?
Yes, well, in the US, they are very hot on how to organise the payment structures in healthcare to try to get value out of healthcare, better quality of care, and to try and increase productivity. So they've got a very long track record in how to incentivise local providers, that's hospitals or primary care physicians, to try to do the right thing, to nudge them towards doing the right thing. They not only do they experiment a great deal, but they also evaluate incredibly well. And we have quite a lot to learn from those kinds of experiments. So those are some things. On the other hand, we've got quite a lot to teach them about, for example, cost effectiveness analysis, and we have set up, for example, the National Institute for Health and Clinical Excellence that looks at the effectiveness of treatments and uses that to inform the payment mechanism in healthcare. So we've got quite a lot there that we can both learn at this very technical level.
And what about with regards to the organisational changes that take place?
Well, what's very interesting in the US is that they are facing, like us, a very poor financial settlement for healthcare. I mean, budgets are squeezed all over the globe, particularly with those countries that have weak economies. And we are facing that very strongly here. So every country is trying to eke out more value out of their health system, out of the healthcare dollar spent, whether it's a private dollar or whether it's a publicly spent dollar, as in this country. And so what we're trying to do is to try to encourage providers of healthcare to offer more value, to offer better quality. And we do that in a range of ways, for example, altering the payment system to try to incentivize better behavior. We try to improve information to try to get people to scrutinize where there are gross variations in care. We try to look at the way healthcare is organized. We know that across many developed countries, including the US, including England, that really over the last 50 years we've been so hospital dominated in our care. It's almost as if modern medicine has really developed hospitals, and there hasn't been concomitant development in primary care. Whereas really, if you think about it, who wants to be in a hospital? Everybody wants to stay well and not incur a hospital admission, not incur that cost. So a lot of the kind of organisational developments are to try to provide incentives, whether they're financial or otherwise, to reverse the flow of patients out of hospital, to try to encourage more self-care, care in primary care, through better care integration, to keep people healthy so that a costly hospital admission is no longer required. So in the US, there have been a lot of interesting organisational developments along something called accountable care organisations, which integrate primary and secondary care. And similarly, there's all those kind of developments that are beginning here as well. So as we progress over time, there's tons to learn there.
And what were your findings with regards to information management activities?
Well, the US obviously has developed its health system on the basis of billing people for care, billing insurance companies, billing individuals. So they have very detailed forensic attention to costs, and they have very detailed granular costs that they can identify that have been incurred by patients. We, on the other hand, haven't had that level of billing because we've never had to bill in that way. So we are, over time, just beginning to develop better costing so that we can not only track what happens to patients in a hospital with respect to their quality, but also the costs of different elements of their care. And it's only with that level of transparency can we then start to be more cost effective. So we've made great headway in primary care with information that they haven't in the US. They've made greater headway in hospitals that we then have to learn from. But we're all on a journey, and I think in those two particular areas we've got a lot to learn.
What would you say were the main conclusions that you've drawn from the paper?
The main conclusions, I think, are do not turn your face away from another healthcare system because of the values on which it is based. Don't turn away from America because it is full of private healthcare, rip-roaring competition, and a lot of waste and unfairness. But look below the waterline at areas of high performance, and try to compare and look very soberly at what is being done there on a range of fronts, and reflect on the lessons from here. And that kind of learning, international learning, not just with America but also with Europe and other countries, even third world countries, means that we can soberly and with humility move forward without having to turn our face against something simply for ideological reasons.
And do you think both the systems are ready to learn from each other?
Not at a political level, but I think at a technical level they are, and that's where a lot of the cross-country fertilisation and exchange should happen. So we wrote our paper in the heat of bipartisan blocks and tensions in the Affordable Care Act in the United States. At the same time, there were bipartisan blocks and tensions with our Health and Social Care Bill. Both those bills have now been passed in America and Britain. We can now get beyond that political heat and into the technical development about how we use these bills to further progress in both of our health systems.
Jennifer, we're going to leave it there, but thank you so much for joining us.
Pleasure.